and NIGF Chandigarh chapter, it gives me immense pleasure to welcome all of you to today's CME. And we have an excellent academic program lined up today, focused on critical and a very good topic, that is obstetric collapse. This is going to be followed by a panel discussion, as we all know, bringing together some experienced clinicians here with us. So I would like to begin by expressing a prayer by
Great Goddess Saraswati.
Navneet ma'am and Bharti ma'am.
Yes. Yes.
Okay.
So Dr. Navneet, करें शुरू?
हाँ, we start. हाँ जी.
Okay. हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ. हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ. हे शारदे माँ, तू स्वर्ग की है संगीत तुझसे, हर शब्द तेरा है हर गीत तुझसे. तू स्वर्ग की देवी है संगीत तुझसे, हर शब्द तेरा है हर गीत तुझसे. हम हैं अकेले, हम हैं
अधूरे, तेरी शरण
हमें प्यार दे माँ. हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें प्यार दे माँ. हे शारदे माँ.
Very lovely.
Very beautifully sung by spontaneous, multi-talented, esteemed peers. So I would like to begin by expressing my sincere gratitude to our chief patron, Dr. Sharda Jain ma'am, respected mentors, office bearers, chairpersons, panelists, and speakers for sparing their valuable time and also for enriching this academic evening. So I would like to begin by expressing my sincere gratitude to ma'am.
I think ma'am
Sharda ma'am.
Ma'am has joined? Probably. Okay.
No.
Ma'am has not joined.
Achha, so then you can call upon Dr. Ragini for the hello.
Okay, so I would request Dr. Ragini ma'am. She is former President NIGF. Ragini ma'am, for the welcome address.
Thank you, Dr. SP.
Presidential address, ma'am.
Yeah, thank you, Dr. SP. Very good evening to one and all. It's really a very happy to see that work of the academic wing, and especially the first program from the Chandigarh, and everybody knew that how partial I am with Chandigarh. It's always in my heart and brain. So the topic chosen is, Preeti has come. So the topic chosen today is the obstetric collapse. I think this is one emergency in obstetrics which can happen at any time. And if we are not prepared, we don't know how to go about it. We can land up with lots of mishap and the medical legal problems also, and we can lose a precious life too. So choosing this subject is really very nice, and I hope Roshanji, you will record it properly and put it on the net, so everybody who has not joined, even can they go through with this great academics which is going to present by the Dr. Meenakshi Rohila. And the most important thing which I can say, I'm the Dr. Manju Verma, the Dean of the Academic Wing of the NIGF, and my teacher. She's there here. Thank you so much, madam, for gracing the occasion and blessing us. Thank you so much. And over to you, Dr. SP, for continuing the program.
Thank you so much, ma'am. We welcome all of you, and we now start with our session 1, that is a talk on obstetric collapse by our very well-known speaker, Dr. Meenakshi Rohila. She is professor and unit head in the Department of Obs and Gynae in PGI Chandigarh. I request, ma'am, to please start.
Bharti, would you invite Dr. Manju also for some brief comments or blessings?
Yes, ma'am, we can definitely. So, before you start with your presentation, we can seek blessings of Dr. Mala and followed by Dr. Manju. So, Dr. Mala, please ask sincere request to give your expert views, please.
Good evening, everyone. It's my pleasure and privilege to be with all of you today evening. And I must congratulate Dr. Ragini Madam, to who has this brilliant idea of having the NIGF academic wing. And of course, under the guidance of Dr. Manju Verma Madam, who is teacher of teachers, we all look forward for very active, interactive session today evening. And these small learnings can go a long way in updating our knowledge as well as all the delegates' knowledge. Over to you to carry on the scientific program.
Shall I share my slides now?
Yes, I think you should start sharing your slides.
Is my slide visible, ma'am?
Yes, ma'am.
Yes.
Okay.
Yes.
Just a minute.
Ma'am, I would also like to invite our chairpersons for the session.
Yes.
Dr. Sadhna Gupta, she is ex-president NIGF. Dr. Navneet Thakkar, ma'am, she is head of the department Obs and Gynae GMC at Chandigarh. Dr. Preeti Jindal, ma'am, she is founder and director at the Touch Clinic, Advanced IVF and Boutique Center, Mohali. And Dr. Mala Srivastav, ma'am, she is HOD Oncology Unit, Gynae Endoscopic and Robotic Surgeon and Senior Consultant and Professor at Sir Gangaram Hospital, New Delhi.
So thank you very much, Aspi, and with my all regards to President NIGF, Dr. Ragini ma'am, President NIGF Academic Wing, Dr. Manju ma'am, Dr. Mala, and Dr. Ruby. I would like to start my session. Thanks for the brief introduction that has been already given. I really want to thank all the team for giving the Chandigarh chapter the first opportunity to start the program of Academic Wing, and I thank all the team of Academic Wing also to make this happen. Thank you very much, ma'am. So starting with the topic, we all know this is a maternal collapse. Whenever we talk about, this is actually an acute event which is involving the cardiorespiratory system and or brain, resulting in a reduced or absent conscious level, and this may happen in a pregnant or maybe in any woman up to 6 weeks after the delivery. So if we see practically, it is a non-specific description, I would say, then can be applied to a variety of medical condition that may range from a simple syncope to cardiac arrest. And if you see the actual collapse that happens once in every 30 to 36,000.
Please mute your mic except Dr. Meenakshi.
Roshan, you can also, keep this setting. Otherwise, they may be. Okay. So coming to the outcome, it is always correlated, and with maternal outcome is mostly related with the fetal outcome as well. And it depends on the promptness we manage and diagnose the collapse and the causes of collapse. If we come to the causes, mostly we see the common causes where the mother collapses, and it may be a hemorrhage, hypertension, it may be a eclamptic woman. Mostly the collapse we see in our labor rooms is the eclamptic woman who is throwing fit and she collapsed. And apart from this, she may also collapse at the time of giving magnesium sulfate also. This is very commonly seen, and at the time of bleeding, massive bleeding, it may be because of the hemorrhage, and it may be unpredictable in cases of pulmonary or amniotic fluid embolus. Commonly, it may be as a syncope, or it may be because of the sepsis, which is very well obvious and can be treated. And maybe some non-obstetric causes also. As I said, it may be because of at the time of spinal anesthesia. It sometimes may be an high spinal, or it may be sometimes a toxicity of the drug which is being given for the spinal, or it may be other causes like trauma, it may be severe asthma, or it may be acute MI these days in pregnant women who are presenting in the late pregnancy in the late age. So coming to the mainly the resuscitation part, before we discuss the resuscitation part, it's very important for all of us to know who are the women actually where we should be very alert that they can have collapse anytime. So we need to see that early warning scoring system in all the women who are presenting to us in the pregnancy. So we need to be very alert to see their mental response, pulse rate, systolic BP, or maybe the oxygen saturation, or maybe the output whenever they are in labor or they are in the emergency. Anytime if the respiratory rate is more than 25 or it is less than 10 breath, she's at very high risk to undergo a collapse. We have to be very alert into that situation. If the BP is less than 90, heart rate is more than 110, or it is less than 55 beats, she's not fully oriented or oriented. We notice anytime we are talking to a woman, she may be at high risk. If the saturation is less than 90%, or when the urine output is less than 100%, less than 100 ml in last 4 hours, as we always keep a watch on all eclamptic women who are getting magnesium sulfate to have an output or all these things. So whenever we talk about the basic steps in resuscitation, it is all same as we do in all the, in any non-pregnant women also, or a men also. This is airway, breathing, circulation and defibrillation. But definitely when we are talking about a pregnant woman, there are many physiological changes due to pregnancy itself that makes our resuscitation sometimes difficult. What can we do? That we have to know why the difficulty is there and how can we modify it. That is very important to know. When we talk about the airway, it may be difficult airway because of the edema which is otherwise there in pregnant women. It may be because of the large breast, or it may be because of the supraglottic edema also. So because of the hormonal changes, there reduce esophageal tone and increase intragastric pressure also, which makes a woman more prone to aspiration and aspiration pneumonitis. If we talk about breathing, definitely there is a reduced chest compliance, and because of the raised diaphragm, there is a decreased functional reserve capacity and increased oxygen requirement consequently. So this is again an issue that may be very important while we are resuscitating a pregnant woman. We have to do some modification in the resuscitation. If we talk about the circulation, it is because of the pressure of the gravid uterus on the aortocaval area that makes the cardiac output return less as in the non-pregnant woman, and that's a very important factor while we are trying to maintain the circulation. So we need to remove that pressure as soon as possible while we are doing resuscitation in a pregnant woman. So in summary, the resuscitation difficulty, all we have, it may be a difficult intubation, there may be a rapid development of the hypoxia, hypercapnia and acidosis, there are chances of aspiration, there are less circulation, maybe because of the aortocaval compression, and these changes may be more even in multiple pregnancy and in an obese woman. So basically we need to modify the airway management. We need to see the uterine displacement. We need to see a deeper chest compression to overcome the reduced chest compliance, and we may need to deliver the fetus within 5 minutes whenever our resuscitation fails. So that is all about the collapse. So once we come to the modification, it is when we talk about the modification in the airway management, we need to first do a jaw thrust with cricoid pressure. We need to lift the jaw. We need to push the cricoid so that it pushes the trachea posteriorly and compresses the esophagus against the cervical vertebrae, and it decreases the chances of aspiration pneumonitis. So we need to use a smaller endotracheal tube many times, and if we have the availability of video laryngoscope, that is very good. But if it is not there, the short laryngoscopic handle may be required. If we talk about the failed intubation, it is more than double in a pregnant woman than in a non-pregnant woman. So if it is possible, a senior person should be there to intubate if at all it is possible. Otherwise, everyone should be aware of the intubation in the pregnant woman. As I talked about the uterine displacement, it has to be there while we are trying to resuscitate a collapsed woman. We need to remove this pressure. It can be done by a simple uterine displacement, or if at all it is not, if you have a uterine displaced board also, that can also be used. And whenever we do a uterine displacement, what we do, we put our both hands below the uterus on the right side of the woman, and we push the uterus up and onto the left side, which is called as up, off and over method, to displace the uterus from the IVC and the aorta. And this is the position which maintains the position in supine position and allow for the effective chest compression at the same time. So this is the thing that we can do. This is another things that is available, may not be available in all our scenario, that if we can keep the stretcher or trolley tilted, and then we can continue the resuscitation in the same position also. So it is very well proven in the literature that if we talk about the venous return or a cardiac output, which is much better in a left lateral position, then we compare with the supine or a dorsal lithotomy position. What is the another modification we need to do in a pregnant woman? We need to put additional pressure on the chest. We need to do a deeper chest compression, and we need to place our hand in the center of the sternum so that we can give her a effective chest compression while doing the CPR. So as far as the next step is required, it is a defibrillation. Actually, it is not a modification required in this step in a pregnant woman, but definitely we need to remove all fetal and uterine monitors if we are going to give a shock to a woman by giving a by using defibrillator. And it is very important to know that it does not cause any harm to the fetus while we are defibrillating a collapsed woman. So why now coming to the next step, that is the urgent delivery of fetus is indicated anytime when we are not able to resuscitate a woman? Yes, it is important, because whatever you do, a resuscitation of a pregnant woman may not be same as a pregnant non-pregnant woman. So it may be the better we can do, but not be the same. So if we are not able to revive the woman after 4 minutes, we need to consider this a delivery of a fetus once the 4 minutes is has completed, because after 5 minutes the brain damage may start, and it is important for the it may be a beneficial for the fetus also. So there are reports that the fetus also has been revived by doing this, and the fetus has been come out live, and the mother has been revived very nicely by doing this. So there are reports whenever we plan for the perimortem cesarean delivery. It has been reported very nicely now in the literature. I will present that whenever we decide that it has to be done there and there, then only. We do not need the patient to the OT, or we do not wait for the sterile area. We just, what we need is the scalpel and or maybe a glove to deliver the baby. A midline vertical incision has to be given, and a fundal or incision has to be given and deliver the baby. And if we revive the woman, then we can shift the woman to OT, and we can do later on all the resuscitation can be continued there. So if we see the guidelines, the primary intention has to be to remove the otocaval compression and to revive the mother, with the secondary goal of saving the fetus. That's very important to know. So if we see the literature, it is the longest review that is available in the literature, which is of 38 perimortem cesarean section, that was done from 1985 to 2004, and this was published in 2005. In this review article, it was seen that out of 34 infant of 28 women, could be survived in this review article, and the neurological outcome was much better in women where the cesarean could be done within 5 minutes of the collapse, and the 20 women could be actually survived, and 12 survived to hospital discharge also. Although there was some insult to the survival also, but could be saved, and some could be sent to the home also. And though I would say only very few could be done within 4 minutes, but still there are some literature and some reports are there. Even if 5 minutes is not there, and fetus is not alive, some benefit to the woman may be there, may not be the full-fledged neurological outcome may be there, but definitely she can be survived. And no patient did the performance of a perimortem cesarean section show the worsening the maternal condition when we did the perimortem cesarean section. So that's very important to know why we are doing this, and it's important to follow. So somehow if we are not able to revive the woman, we continue this and we do this 30 minutes, and if the return is there, we need to continue the CPR. And by doing all this, we need to while we are doing all this steps, we need to keep the family well informed. We need to keep a cool and calm, although we are doing step by step steps, and we are well firm in doing our duty, but we need to keep a cool and calm, and we have to assess to the loved one whenever they ask for this situation. And it's not important to get a informed consent at the time of perimortem cesarean delivery also. It has been said in the literature that it can be considered as a doctrine of doing and the best interest of the patient. And if it is good if we can inform the patient, otherwise also we need to inform them the situation of the patient, and they should be well informed if it is better. So after doing this, it is very important to brief the situation to all the patient and the relative. It's very important to do accurate documentation, debrief the relatives and the patient, and the review of the case should definitely has to be there in the morbidity or in the mortality meeting, whatever is the consequence of this management of the collapses there. So just to conclude, I will come to a brief outline of this algorithm of the resuscitation. So whenever we need notice a woman who is collapsing, we need to stimulate and just assess the response. Whether sometimes if we our assessment may be wrong, and she may not be collapsing, she may not be by chance may not be responding to the situation. So need to assess that, and if it is if she responds to our stimulation, it's well and good. We should keep the woman in the left lateral position. Maybe she was in a syncope, so keep her in a left lateral position. Assess her BP, heart rate, pulse rate, and see for any warning sign if she has, and identify any cause of collapse if she was having any, and treat that accordingly. But if she does not respond, shout for help and ask for the CPR team and the CPR trolley also. Just immediately look for the airway. If it is open, if it is not open, chest for the any obstruction, or do a head tilt and a chin tilt to keep her airway open till we get the things to make the airway open. So if within 5 or 10 seconds, assess for the breathing and the circulation. Look for the chest movements, listen for the breath sound, and feel for the air if we can see if she is breathing. If she is response, if she is breathing, even the circulation is there, then definitely again continue with the left lateral, see for any warning sign and identify any cause and treat the cause. But if you notice there is no breathing, start the CPR immediately, and it is to be done in the ratio of 30 to 2, 30 is to 2. In 30 has to be chest compression, and they should be doing at the chest compression should be at the depth of 5 to 6 centimeter at the chest center of the chest, as I said earlier also, and 2 ventilation should be done at the compression after the compression of the 30 chest compression. So this is very important to continue more of the compression rather than doing ventilation. We do not want to interrupt the chest compression by doing the ventilation, but it is very important by doing 5 cycles of this CPR, by doing this 30s to 2, by doing 5 times, it will be a 1 cycle. So we will do this 5 times, and then we will see again the pulse, and we see that whether the breathing is there, and now it is there, and we will see for the availability of the ventilator, defibrillator, and the monitor also. The team with us will see this, and the 2 team will be doing this simultaneously. By doing this, we will simultaneously see if there are any causes of the collapse if she had, and we'll treat that accordingly. I will send the samples accordingly if her spontaneous circulation return. If still she does not her circulation do not return, and we attach her to monitor, and we attach to the defibrillator also. Now we see the rhythm. What is the rhythm in the monitor? If it is a shockable rhythm, if we see the ventricular fibrillation, or it is a ventricular tachycardia, it is the right time to give a shock of 200 joules to the woman by taking all the precaution as I said earlier, and continue the CPR as such, same for another 2 minutes. If it is not a shockable rhythm, like if it is just a pulse activated activities there, or it is an asystole, continue this CPR in the same ratio for another 22 minutes. So whenever we are doing this, we need to there's another team, we need to be another person who should be be looking after if for there any reversible cause of the collapse. If we can look, like as I said earlier, in what situation patient is this? Is she received a local anesthesia? Is she received a spinal? Is she a patient of eclampsia? Is she bleeding? So is she having any electrolyte imbalance? So these are the causes which are actually very easily treatable and reversible, and if they are treated at the very right time, the collapse can be very easily reversed also. And while we are doing this steps of resuscitation, we should be continuing to look for the good IVSS, good IVSS, and adrenaline or epinephrine should be given 1 milligram every 3 to 5 minutes. High flow oxygen should be continued. Intubation should have been done by this time, and we should continue chest compression, and we should always look for the reversible causes at the same time. Simultaneously, these things should be done. So coming to the last step, we should, as I said, we should consider perimortem cesarean delivery. We call it as a perimortem because we have revived the woman, and if at all we have not revived the woman, 4 minutes has already elapsed, and it is a very right time that we do a cesarean delivery to avoid brain damage in a woman. And if we can revive the woman before the brain damage of the woman, that will be well and good. So if we should try to do cesarean delivery. If no response, after the 4 minutes of CPR, and within the 5 minutes, the delivery should have been happened, and it should have been happened there and then only, as I said earlier. So it is definitely a multidisciplinary team approach. We need to prepare our team. We need to be prepared for this scenario in our labor room. We need to have a good communication between our nursing staff, between our ourself as an obstetrician, with anesthetist, and with the intensivist who can come very fast and do intubation, or can put her on a ventilator if at all we have in a pregnant woman. We need an special anesthetist, and if at all we can do that, is very good. And the most important thing is that we should keep on doing this regular drill to make ourselves aware for this collapse or any emergency situation in the labor room, so that we are all aware of this, and we should be ready for this situation anytime. So with this I will like to thank all of you to giving me this opportunity, and we should always all pray that no woman should die while bringing life into this world. Thank you very much.
Thank you, Dr. Meenakshi. It was such a beautiful presentation. And I'm sure you covered so nicely how to resuscitate these women. The very important key point is that all the people should be trained in BLS, basic life support. So every doctor should have BLS certificate, and they should keep on getting these certificates or these training every 2 years at least, so that they are up to date about the resuscitation. Even as a doctor, not only as an obstetrician, if you are traveling anywhere, you should know the basic life support, which Dr. Meenakshi so rightly pointed. Earlier, when we were young, we used to have that 15 compression, and then after every compression, the breath, but now it's changed, 30:2. And second very important point is that shout for help. One person cannot do everything. So as soon as a woman collapses, we should definitely try to get as many hands on board as possible. But very nicely covered. Thank you. And thank you, Dr. Ragini, for such a beautiful initiative.
Excellent scientific deliberation, Dr. Meenakshi. And you have rightly said that these things should be practiced. There should be regular drills in the labor room, as well as in the wards, obstetric wards, because sometimes the patient maternal collapse can occur even in the postpartum ward. And we have to really literally rush the patient to ICU or CCU, as the case may be. So these kind of regular drills should occur in the wards, antenatal wards, postpartum wards, as well as in the labor room. And every member of the team should be familiarized with the consequences and what to do step by step. Excellent guidance you gave, and I'm sure everybody has benefited from your scientific deliberation.
Thank you. Ma'am, just
initiate code blue immediately. Code blue should be initiated immediately.
Yes.
In this.
Yes, ma'am. But at many places there is not code blue system is not there. But yes, it should be there. And most of the good hospitals, they have code blue system. Yes.
Yeah.
And as
It is my
Dr.
small suggestion that algorithms of this maternal collapse should be pasted in our labor wards. And just like we used to revise our tables at young age, we can revise them. So in the antenatal ward, in the postnatal ward, as well as the labor ward, I feel these three wards should have these algorithms. They have come up after real hard work by the UK NICE guidelines. So I think we should all embrace this and put it into practice for our patients. This is my suggestion.
Yes, thank you. Regarding the, as Preeti said, Dr. Preeti Jindal said, regarding the course of BLS, Anesthesia Department of PGI does this very regularly, and many people come for this course, and they do very frequently. So anybody who's interested can come for this course.
Yes, it's very important. Thank you, Dr. Meenakshi. And even in Fortis, it is done. I mean, I'm just telling the places, Fortis, PGI, I'm sure GMCH must also be conducting. So ideally, every doctor should take this BLS, and if after that ACLS certification, it's very helpful.
Hello.
Yes.
Hello, Dr. Meenakshi. So, do you have any experience, and would you like to share any experience regarding perimortem cesarean also, ma'am? So, I think
yes, I made a slide, but actually I made it in the I could not display that. Actually, even in the PGI, I would say that when the collapse was there in the OT itself. I mean, my experience is that in my two patients, I had collapse before the cesarean section. It was immediately after the spinal anesthesia. In one, probably it was because of the hypotension. When initially we were not used to it, it's a very long back time, I am saying. Initially, we were not used to preload the patient who were fasting for a very long time. And now the things have changed. We preload the patient before we give spinal anesthesia to women. So I noticed woman that patient consultant was not around, and noted patient that she's not responding when I was going to start a cesarean section. I shout for help, and then by chance, if everything could be done very nicely, and immediately we took the baby out, and the mother also could be revived. This has happened one in the patient immediate after anesthesia. Probably in one it was because of the hypovolemia, and in the second case probably it was of the high spinal. I noted, because I would never forget that it was a high spinal, and that is also, as I said, is a very common cause. It was very well managed by the anesthetist team. She was intubated at the very right time, and we took the baby out, and everything happened very smoothly. But definitely, I would say, if you ask about the experience in the labor room itself, we also do not have very good experience. We could rarely do perimortem cesarean section within 4 minutes. But we could do this in one patient when it was done in a trauma center, when the patient was on a trolley, and she came after a road traffic accident, and she had spinal injury also. So it was done by one of our learned junior faculty. So she did a perimortem cesarean there and then only. If we had return of spontaneous circulation then and there, though very unfortunately she died because of the multiple injury, she could not be survived. Fetus was already dead, but we could get the return of the spontaneous circulation. But we are still, in the process of doing this, and we try to do this at the earliest possible. But I would still say that we need to do much more on this. We need to do much more perimortem cesarean. As I said, they are more in for the maternal resuscitation than to salvage the fetus. That's our secondary goal. So that is what my experience is.
Ma'am, I have a question with you, ma'am. I want to know, are you doing regular drills for the residents? Because in the medical college, I'm genuinely interested, because we are not doing it in IGMC Shimla. I think that there should be drills, because they are the first respondents to any kind of collapse, because as consultants we reach late or something.
Yes, you have very rightly have asked, Nidhi. Actually, I don't know whether you have attended that or not. We have done we have done workshop on this I mean, very recently, I mean, I won't say very recently, but we have done a workshop on collapse, and we did a drill also that was done on the LT1 in the stage. Maybe, probably you were not there, but we have done on the hemorrhage, collapse, sepsis, and we keep on doing this.
We did a North Zone conference.
Yes, we
And
did
that was
a
long
North Zone
back, I
conference.
suppose. That was in
September
COVID times, I
25.
suppose.
Yes,
But we
yes.
will let you know, Nidhi, whenever we do this, and we
Please,
will.
ma'am, I request you to do
Yeah,
this.
As a routine in our hospital, all the PG students are supposed to do BCLS as well as advanced cardiac resuscitation courses. It's a part of their curriculum.
Right.
Okay.
Ma'am, that residents are doing in our college also, but maternal collapse, I feel personally, is something different from the regular
Yes.
BLS or ACLS.
They tell you a general
kind
thing.
of instincts.
Yes.
So I think with this we can end up the first session. But before we start the next session, I would like to seek blessings from Dr. Manju, Dean Academic Wing. Madam, our sincere apologies. Sorry, we should have sought your blessings in the beginning only. But sorry on our part. But we would, before we proceed, Ashpi, would you like to invite Dr. Manju and for her blessings and her message?
Madam, मेरे ख्याल से Madam is not there.
Madam said she's there. We just talked to her.
So we have regular drills in our hospital, and because that trains our PG students. Right from the very first year, they are trained. At least they will do something and regular there.
एक बार आप उन्हें कॉल कर लीजिए, वो हैं
Ma'am, we have called her. So she said she will.
She is not joined.
आप एक बार और कर लो, Dr. Bharti.
Okay, so
we'll just wait for 2 minutes for her to join before we
can
take
have
the
a
next
discussion.
session.
We can
I think
continue
this
with
is
the
her
discussion.
honor. This is
Ma'am, then we can continue with the discussion only, sharing our
no.
experiences.
Let's please call up ma'am
Yes,
till
yes,
then.
yes.
We can have a 1-minute break. It's
Yes,
okay.
yes, we can have a 1-minute break, or we can discuss Dr. Meenakshi the previous session.
Dr. Navneet, you can also share your experience, or anyone else about the.
My recent experiences in the postpartum ward, and there was sudden maternal collapse, and it was following the IV Metrogyl.
Okay.
So we reported an adverse drug reaction. So adverse drug reaction is also one of the causes of maternal collapse. And we gave her a complaint of breathlessness. And 2 hours after the this resuscitation and keeping her in HDO on monitoring, she was fine. So it was, and we reported this as an adverse drug reaction to metronidazole. So this was lately, we around 10 days back, we experienced this in our postpartum ward, sudden collapse of the patient.
Actually,
and it was due to adverse drug reaction.
Okay. Actually, for resuscitation, this trolley should be, or kit of the resuscitation should be there in the emergency as well as in the postpartum ward. That's very important, because the collapse might occur in the postpartum ward as well. So that's an important thing.
Yes. And then observation in the HDU also helped the patient.
Yes.
And anytime intubation is available with us there.
Yes.
Navneet ma'am, do you remember which company Metrogyl was it? Because it's very rare to know, and we all should be aware, because we are using.
We have sent the batch numbers to our MS and everything, and we have a drug reporting committee. Dr. Sangeeta Bhavra, physiology says she does take into consideration.
Ma'am, do you remember the company? So that
company, it was a hospital supply, because we are JSSK people, na? So we give free delivery services, free of cost, everything.
Okay. Okay. Thank you.
I will see the company and share with you on WhatsApp.
Right, ma'am. Thank you so much.
Sure,
patient to discuss. I have a patient to discuss.
Please share, ma'am, please.
This was an IVF treated pregnancy, twins, and it was a planned cesarean section. The patient was very obese, and the spinal high spinal, and immediately our anesthetist was good. Patient complained कि हाथ में झिंझनी हो रही है और होठ में भी कुछ लग रहा है. and उसको respiratory arrest होने से पहले intubate करके, and then we did the cesarean section. Luckily, patient was saved, and both the babies were also okay.
Okay, ma'am. That's good.
Actually, I'm at the airport, so not able to communicate so much.
Yes, ma'am. Your voice is breaking actually in between.
Yeah. I'm sorry.
No, it's okay, ma'am. It's okay.
So
basically, it's the. So you can continue, Bharti.
No. Ma'am, you can continue. I am trying to connect madam, but somehow I think we are not able to connect with her. Till then, we can at least, I can start my screen.
You can, Aspi can.
Hanji. So, to keep the program on schedule, maybe shall we move to the next segment, Bharti ma'am?
I think we are waiting for Dr. Manju, but Dr. Manju.
I've sent you the number.
No, but madam, her number. Okay.
Bharti, you can start. I will call madam.
Yeah. I think we should continue. Whenever ma'am joins, we can take her.
Just wait for 1 minute. I think there is no harm. You can keep the slides on, but
I can share.
Please wait for ma'am to join. Please, this much we can do, I think.
Navneet ma'am, regarding IV Metrogel, there can be some allergens in the IV Metrogel because it is a GSSK supply and government supply, which is going. So might be the reason for causing that collapse might be anaphylaxis to the drug.
Yes.
Or the allergen which is which may be in that injection. Maybe.
Yeah, but we all said and done, there was maternal collapse, and secondly, it was an adverse drug reaction because patient recovered immediately. Yeah, after 2 hours of observation.
She had a breathing difficulty as well, laryngeal edema, as well as the rashes and all.
No, she had only respiratory distress.
Only respiratory distress.
Only respiratory distress. That comes in the maternal collapse, no? Respiratory failure, CNS failure, and cardiovascular failure. 3 failure aate hain usme. The definition.
The causes have to be identified. That's what the stress is on that only.
There was no other cause, there was no PPH, nothing. कुछ भी नहीं था. And वो drip जैसे खत्म हुई, and that moment only, the whole 100 ml had gone. We just stopped the drip, and itne mein she collapsed. We were there only, our team was there. Our doctor was on round. First on call was on rounds. And that's how she picked up immediately.
Picking up the cause is essential.
Yes. So, anybody else who wants?
Dr. Bharti, बात हुई आपकी मैम से?
मैम चल रहा है, डॉक्टर मीनाक्षी कर रहे हैं, बिजी है उनका.
अच्छा जी, okay.
So, ma'am, here I would like to add one of my experiences. I was a resident in PGI, and we had a heart disease patient, and it was a protocol in PGI that whenever the patient comes as laboring in heart disease, we give the benzathine penicillin immediately, whatever time it has been given. And we charted it as IM, and sister read it as IV. So this is a very important thing. And she was a new sister in the ward, and she gave it IV, and patient on spot, she collapsed. So this is also very important that the route of the drug, you have to ensure that sister is giving it rightly or not, especially these kind of drugs which can be life-threatening. And I have seen losing a patient with Buscopan also. She has severe drug allergic reaction with even Buscopan.
So this was my most recent experience with maternal collapse, so I'm sharing. We just had it 10 days back.
I have experience of 3 maternal collapse. The first was she was fully dilated and she was bearing down and she collapsed. Our assistant professor, apart from resuscitative measures, she took out the baby. The baby survived, but mother could not survive. The second was she came with APH. In emergency, our AP was sitting and she collapsed. She did a cesarean section there and then, perimortem, and the mother also survived, and we reported this. This was 4 years back. And third was similar to Dr. Navneet. in the postpartum ward, but she was an unbooked patient. We did a cesarean, and she had a ejection fraction peripartum cardiomyopathy, and then we shifted her to cardiology, CCU, and she also survived.
Recently, we had a experience of placenta accreta in PGI. So this patient, she had come to us at 24 weeks of
Bharti
gestation.
or Aspi,
Yes, ma'am.
am I audible?
Yes, yes, ma'am. You are audible.
We can continue with the next
Okay.
session.
Yes, yes, we are continuing.
Madam will join in the end. She's
Okay.
busy,
Maternal
so-
collapse.
Okay.
So, ma'am,
Thank you, Dr. Meenakshi.
Bharti ma'am, you want to share or shall we move ahead?
No, please, you just first introduce the chairpersons, panelists, and moderators. Welcome
we
them,
are-
and then we start.
So we are moving to the second session of the day. That is a panel discussion. The topic is maternal collapse. Every life is worth the rush. So first of all, I would like to invite the chairpersons. Dr. Ruby Bhatia ma'am. She's professor and head Department of Obs and Gynae, MMI, MSR, Molana. Dr. Vineet Nagpal, ma'am is senior consultant at Landmark Hospital, Chandigarh. She was also formerly assistant director at Health and Family Welfare, Chandigarh. Dr. Monica Agarwal, ma'am, she's senior consultant at Cloud9 Hospital, Chandigarh. Dr. Monica Narang, ma'am, is director at Blessings Hospital, Zirakpur. So our panelists for this discussion, they are Dr. Ruchi Rai Ahuja, ma'am, is senior consultant, breast physician, infertility and cosmetic gynecologist at Ahuja Clinic, Chandigarh. Dr. Snigdha, she's additional professor at PGI, Chandigarh. Dr. Navdeep Kaur, she is senior consultant obstetrician and laparoscopic surgeon at Motherhood Hospital, Mohali, and Dr. Sunita Goyal, ma'am is additional professor at GMCH, Chandigarh. I would invite the panelists for the panel discussion. May I please invite our moderators for the session, Dr. Bharti ma'am. Ma'am is associate professor at PGI Chandigarh, and Dr. Nidhi Jindal, ma'am is assistant professor at IGMC Chandigarh, Shimla.
Thank you, Ashvi. I just got a message from Dr. Sunita 32 that she's stuck in sub-emergency, but she will soon join, right?
Okay.
So, is my slide visible to all?
Yes, ma'am.
Yes.
So, should we start?
Yes, sure.
So, these have been introduced. So, Dr. Komal, anesthetist, she will also be joining later on just for her expert comments and sharing the experience. So, no woman should die while bringing life into this world. So before we just start with case scenarios, just wanted to recapitulate the definitions or how, the causes of maternal collapse. So Dr. Ruchi Rai, so can you just go through the maternal collapse definition and the causes of these?
Yes, maternal collapse is an acute event involving the cardiorespiratory system and or the CNS system. It leads to a reduced or absent conscious level. Potentially, it can escalate up to a cardiac arrest or even death of the patient. And this all happens during any course of pregnancy up to 6 weeks.
Yes.
So,
right.
yeah.
Yes.
So
these
the reasons
causes, right?
From head to toe, we can see eclampsia, epilepsy, cardio, cerebrovascular accidents,
paracetamol, siliciopeptidase.
vasovagal response
Hello.
in the heart, MI, arrhythmias, peripartum cardiomyopathy, congenital heart disease, or dissection of the aorta. It can occur because of anaphylaxis, asthma, embolism, pulmonary edema.
Yes. So I think these causes has been told,
These
right?
are the causes, and we can actually remember it by the mnemonic 4 H's and 4 T's. So the 4 H's can be hypovolemia, hypoxia, hyper or hyperkalemia, hypothermia. The T's are thromboembolism, toxicity, tension pneumothorax, tamponade, and not to forget eclampsia and preeclampsia.
Okay. So the challenges definitely we do all understand because of hemodynamics changes in the pregnancy. So we have an impact on resuscitations, and there can be impact on respiratory and other changes which can make the difficult resuscitation in these pregnant females, right? And this early warning signs that Dr. Meenakshi has already told about. So we have to be vigilant enough to identify all the signs to pick up that there is a likelihood of maternal deterioration. So now we start with the case-based discussion. Nidhi, would you like to take the first case?
Yes, ma'am. Sure. Thank you for giving me first number case. So this is the case scenario for the patient. She is the 30 years old primary gravid, well supervised and immunized, but at 24 weeks period of gestation, she was diagnosed with pregnancy-induced hypertension, and she was started on antihypertensives. She was a regular patient. BP was under control, and investigation still her term workup was normal. Ma'am, next slide, please.
Yes.
So patient came into spontaneous labor at 36 plus 2 weeks period of gestation, but on admission, her BP was found to be 160 by 110. Considering that she was already a case of PIH and this was probably severe preeclampsia at term, so patient was admitted in high dependency unit and Maxif was started immediately. And to control her blood pressure during labor, immediate IV labetalol was also given. Patient went into good spontaneous labor. She was almost 4 to 5 centimeter dilated with good uterine and regular contractions, and her effacement was also very good. But suddenly, patient had through a generalized tonic-clonic convulsion, and patient suddenly collapsed. So this was the case scenario. Dr. Snigdha, the question is for you. What do you think has happened to the patient? Has she suffered some cardiac or respiratory arrest or something else? Or if it is the arrest, then what should be the first responder do?
So they can, am I audible?
Yes,
you are audible.
So in this case, after a generalized tonic-clonic seizure, that is eclampsia, the patient might have had aspirated. So this can be one of the cause. There can be another cause which the eclampsia might have led to intraventricular hemorrhage, that is brain hemorrhage in brain. So that might lead to a cardiopulmonary arrest or apart from this,
do you think it can be normal?
The most common cause of going into cardiopulmonary arrest or maternal collapse is epileptic seizures or eclampsia per se. So these can be the reasons of having a maternal collapse after eclampsia. So the first and the foremost step should be to assess the patient, whether she is responding to your commands or not. So you need to tap on the shoulders of the patient and then assess her response, whether she is responding to your commands. If not, then immediately, as ma'am said in earlier lecture, that call for help and call for cardiopulmonary team as well, cardiac arrest team. So and if any hospital has a blue code, then just switch on the blue code and then call all the team members. So the team members should include anesthesiologist, senior obstetricians, the neonatologist in case a delivery is going to happen or about to happen. So in this case, per se, anesthetist and obstetrician should be available, and there should be enough people so that one should be appointed as a leader so that she can give instructions to all the other people, and there should be one person who is documenting everything, another person who is doing the uterine tilt, and then after calling for help and having everyone ready, and while everyone is going to arrive, you can assess for breathing as well as you can assess for the pulse rate. So assessing for breathing, if she is not breathing, you can do a head tilt and chin lift. So apart from that, you can just have a person to put the IV bore wide IV lines, IV bore cannula that is of 16 gauge gray, because it facilitates fluid of around 120 milliliter per minute. So in cases of eclampsia, we need to be careful regarding the fluid resuscitation, because then there might be overload and the patient might be into pulmonary edema as well. So following which, when the help has arrived, you can now designate every people what to do, and so the anesthesiologist can check for airway and then go on for intubation and airway securing, and then in the meantime, if the flowchart goes like this, if we are not able to ascertain the breathing as well as the pulse rate, then start CPR immediately. And CPR, as ma'am has said, that it should be at the depth of 5 to 6 centimeters. So it should be 30:2 cycle, and till the airway is secured. But when the airway is secured, it should be 100 to 120 per minute, and then along with the high flow oxygen, which is going through which is going through the tube. And yes, while intubation, we need to remember that the endotracheal tube should be cuffed and should be a lower size, that is 6.5 to 7 centimeter, so that because there is laryngeal edema as well, so we can encounter difficult intubation, as well as we should ensure that there is no aspiration while doing so. So
Okay. Thank you, Dr. Snigdha. You have well elaborated what can be the probable causes and what can be done in different kind of scenarios. Dr. Bharti, ma'am, your slides are not visible to me.
Yeah, somehow I think
Now it's visible.
Yes, visible, right?
So we did all this, but in between I have a doubt. Dr. Snigdha just mentioned about the uterine displacement. So what is that?
Yes, so what uterine displacement
Dr.
is
Snigdha,
until and
sorry to
unless.
interrupt you. The question is for Dr. Navdeep. I'm so sorry to interrupt you. But ma'am, slide please, Dr. Bharti.
Yes, it should
Uterine
be visible.
No,
Yes,
ma'am.
one thing from more from my side, because this is eclampsia, I forgot to mention that yes, delivery needs to be conducted, and MACSELF is to be given.
Yes.
So for this patient person.
Nidhi, my slides are visible, right?
Ma'am, go to the previous question slide, the uterine displacement slide, please.
Yes.
Yeah, previous one more slide, previous. Yes. So, Navdeep, ma'am, hello. And this question is for you. Manual left uterine displacement, how it helps us in maternal collapse resuscitation. Can you please tell us, ma'am?
Yeah, sure. This is actually a life-saving maneuver. Since the uterus is more than 20 weeks of size, it is compressing the vena cava as well as the aorta. So it will decrease the venous return and cardiac output. While somebody is doing CPR, the other person can stand on the left side of the patient and pull the uterus toward the left and towards the upper side. So it will decompresses the inferior vena cava and also the aorta. While one person is doing CPR, other person is doing this maneuver, it will helps in decompression of both the aorta and the vena cava, resulting in improving the venous return, improving the cardiac output, and also it will improve the chest compressions. And it should be done with both the hand. Pull the uterus towards the left and towards upper side and maintain it continuously till the other person is doing the resuscitations. And also you can tilt the table little towards the left side also.
Or you can put a pillow also on the right side of the patient to tilt the uterus.
Tilt the uterus, tilt the table, tilt the patient, any way, tilt the patient towards a little towards the left side. So basically, it will decompress the vena cava and the aorta.
So
and
the easy way to remember this is up, off, and over. So this is how we have to do it. Thank you, ma'am. Thank you for this. Bharti ma'am, please go to the last slide of this.
I would like to add something. Actually,
I would like to add to. I'm sorry.
Yes, please.
I just wanted to add, when we talk about tilt,
yes,
we always talk the tilt should be at least from 15 to 30 degrees. This because that has to be told. How much tilt? Because obviously the person who's helping, they need to be told, and it has to be very specific.
Yes.
Yeah, please.
It has been seen and said that tilting, lifting the uterus is better than tilting the patient as a whole, because then doing CPR with a tilted patient is a bit difficult. Chest compressions, basically.
Yes.
So better is uterine displacement rather than tilting.
Yes. So important message.
Ma'am, now we move to slide. We are done with case number 1, ma'am. So somehow happily patient responded to this minimal management of tilting and airway maintaining, and when large bore cannula was patient responded, so probably it was a post GTCS unconsciousness in the patient. She delivered normally a live born baby, healthy baby, 2.7 kgs, and MACSELF was continued in this patient till 24 hours. Now we proceed to the case number 2, which will be taken over by Bharti. Thank you.
Thank you, Nidhi. So coming to the next case. So we are talking about a patient who has a normal previous delivery, coming to us as 37 weeks of gestation, and she is having the good uterine contractions, progressing well. So at morning 10:30 a.m., her membranes ruptured spontaneously with good progress, and patient had delivered after 2 hours of the membrane rupture. So we followed the AM TSL third stage of the labor. The placenta removed by controlled contraction. It came out within 5 minutes, but somehow after the placental removal, patient is complaining that she's having giddiness, shortness of breath, and became unconsciousness. At this point of time, one resident saw that her pulse rate is 100, BP is 80/50, saturation is 75%, and we got the ABG done, which is suggestive of respiratory acidosis with increased carbon dioxide retention. So now, at this point of time, what differentials come to our mind? So, would like to have a word from Snigdha. So, how would you basically keep the differentials in mind and your management strategy targeted to this patient for the management?
So, what comes in my mind regarding this patient is maybe she can be an undiagnosed, though she was adequately book supervised, but still someone might have forgot to put a stat on her chest and hear the heart sounds. So maybe this case might have been a case of undiagnosed heart disease. So because leading to collapse in immediate postpartum period, there is, because we all know there is a high chance of collapse, because the cardiac output is too high at that time. And so next can be embolism, considering that within 30 minutes of delivery, she had collapsed. So this can be an amniotic fluid case of amniotic fluid embolism. And this can be a case of PPH as well, because after 5 minutes delivery, she went into collapse. So might be you have not mentioned regarding bleeding and PPH. So,
Yes.
So these are the things which comes into mind. She never went into eclampsia. So, but yes, these are the three things which comes into my mind.
When you feel that there can be a feasibility of amniotic fluid embolism in such patients, or when they are seen more commonly in
So when the patient has been totally uncomplicated, there are few risk factors regarding amniotic fluid embolism. So if the patient was induced, so there is high chances of having amniotic fluid embolism in these patients. If the patient had if she is twin pregnancy, if in case cesarean is done, instrumental vaginal delivery is one of the risk factors. So we can just be assured, we can just have these risk factors into the scene and keep one of the diagnosis of maternal collapse as amniotic fluid embolism. And when it is said, it can happen during a labor as well as within 30 minutes of delivery on the table without any, excluding all the other causes of maternal collapse. So the criteria for amniotic fluid embolism is sudden cardiopulmonary collapse, be it hypotension or hypoxia, and and also with overt disseminated intravascular coagulopathy, which is shown on the laboratory parameters with laboratory confirmation. And as I said, it should be during delivery or within 30 minutes of the delivery. And one of the criteria is there should be no fever. So this is a Clark criteria for diagnosis of amniotic fluid embolism.
Dr. Bharti, good
yes,
evening.
Yes, hello, ma'am. Hello.
So one thing, sorry for joining in between. I was like, I told you, I'm still at the airport only.
Please continue, yes, ma'am.
Dr. Bharti, I would like to add here, because in the teaching institutes, it is very important to tell the residents or the students about the fourth stage of labor.
Yes.
That is very important. That is 1 hour after delivery. You did the delivery, everything went uneventful. And within half an hour, we have a maternal collapse. So that is very important, that never to leave the patient unattended at least 1 to 2 hours after delivery. So that fourth stage of labor is very, very important.
Yes, so that is a very well taken point, madam. So, yes, we know the consequences and cascades, how this is happening, and hypoxia leading to hypotension, conjunctive coagulopathy. So we have to be prompt in resuscitating these patients, and we have standard guidelines for amniotic fluid embolism and their managements. So, would like to know about the cardiopulmonary resuscitation steps again, revision, if somehow this patient collapses the moment you basically ask for help. So how we are going to proceed and further resuscitate until you call your anesthetist, at least we should know the basics. So Snigdha, can you read out the basic steps?
Yes, ma'am, I can read out again the steps. So in case, as I said earlier, in case you find that there is no breathing, there is no air which you can feel, and the patient has collapsed with no pulse, so we need to start the CPR then and there. So CPR needs to be effective. So if the bed is not if it is air mattress, then it might not be effective. So a board needs to be placed behind the just beneath the patient. In case the bed is all right for CPR, then we need to start CPR while 30 chest compressions and then 2 breaths. It constitutes 1 cycle. So the chest compression should be good, as told by ma'am. The hand should be held like this, in this fashion, and then with the heel of the palm we need to push it hard, and we need to achieve a 5 to 6 centimeter depth, so that if an effective cardiac chest compressions is being given. So it is said push hard and push fast. We need to be fast, and the compression rate should be 100 to 120 per minute. And the most important thing during chest compression is that we should give time for the chest to recoil again, because then making chest compressions and not allowing would not allow the oxygen to go inside, and would not allow the heart to recoil, and will compromise the cardiac blood flow as well. So these are the points.
Okay.
For effective chest compressions.
Yes.
Should I continue again?
How many cycles of CPR you can continue, or anything
yes, so
else
before checking the pulse rate of the patient, we need to give 5 cycles, as already stated by Meenakshi ma'am earlier. And then we need to attach all the monitors. Since then the help might have arrived, so we need to attach the patient to the monitors as well. We need to check for the rhythm. If the rhythm is shockable, that is there is VTAC, or then we need to give shock, and we need to see the environment, whether it is safe, no one is touching the patient, and then we need to clear everything, and then we need to give the 200 joules shock. And in case it is not there is asystole, or it is not it is not shockable, then we need to continue with the CPR, and we should not forget about the drugs. So we need to assess the cause of the maternal collapse, and thereby we need to give drugs accordingly. As in my case, as in earlier case, there was eclampsia, so we need not forget about giving Maxaf. And after that, what we need to do is secure the airway, as in we need to take the smaller size of the endotracheal tube, and we need to take laryngoscope in case it is difficult airway, and we assume that it might be difficult airway, so a laryngoscope is required. A video laryngoscope might be beneficial in these cases. So after intubation, after securing the airway, we need to attach with a high flow with the ventilator, and it should be 100% high flow if we have not intubated, because then as it is seen that physiological changes lead to less reserve, and the requirement for the oxygen is more in these cases. So after securing the airway, then we need to then we need to continue with the chest compressions as well. And after 4 minutes has passed, and after giving effective CPR, if your CPR was effective till 4 minutes and still the patient has not recovered, not revived, so we need to consider doing a resuscitative hysterotomy then and there, with only a scalpel in our hand and something to tie the cord with. So after doing a resuscitative hysterotomy, we need to continue the CPR until the patient has revived. And
Thank you, Snigdha. So basically you have enumerated everything about resuscitation. So now, Dr. Navdeep, we would like to hear from you about this case. She is the one who is admitted at the term for the safe confinement, and patient had a cephalic presentation. She went into labor and she has delivered uneventfully. So At around 3:30 p.m., she had the delivery, but we realized that there are no signs of placental separation even after 20-30 minutes. So, third-year resident on duty attempted manual removal of placenta, and during the procedure, the patient complained of giddiness and fainted. So, Dr. Navdeep, are you there?
Yes, Dr.
Yes,
Bharti.
So what would come to your mind after your resident is telling you that, madam, I was trying to attempt this manual placental removal, but somehow the patient has fainted or collapsed. So how would you proceed, and what would you like to make that diagnosis and treat at the same point of time?
The first is Dr. Bharti. The first foremost come is that is a vasovagal attack that can be secondary to the manual removal of placenta in labor room because anesthesia has not been given.
Yes.
Secondly, it can be inversion of the uterus can be there that can be checked at then and there, and by placing the hand inside the uterus, we can inversion can be corrected at the same time. And if anything like vasovagal attack has occurred, or we are finding out that it is a case of uterine inversion, then same inform the IV access, large bore IV access, inform the obstetric registrar and anesthesia people, and plan for anesthesia, transfer to the theater, antibiotic as a guidelines are given, and then manual removal of placenta should be done under the anesthesia by a senior obstetrician. And if there is a PPH, then we need to take care the PPH according to our guidelines.
Yes. So Dr. Ruchi Rai is there? Okay.
Yes, ma'am. Yes, ma'am.
So can you elaborate about the manual removal of placenta? That how do you proceed?
Under anesthesia.
When you anticipate in all these conditions, when you anticipate that there is likely possibility that this patient can have a retained placenta.
So we secure the IV line. We send investigations. We start IV fluids. We arrange blood. Call for help. Give her antibiotics, and under anesthesia. Under anesthesia, we will be removing the placenta, and we'll be well prepared for managing any kind of PPH which might happen.
Yes. So,
Bharti, I would like to add here.
Yes, ma'am.
I think whenever we are doing manual removal of placenta, first of all, catheterize the bladder. That is a very basic thing. So this is very important. Catheterize the bladder, and then start with the manual removal of placenta.
Yes. So before Dr. Komal, are you there?
Yeah, I'm here.
Yeah. Dr. Komal is a part of our critical care anesthetist from anesthesia, and she's a part of our obstetrical team also. So Dr. Komal like to share experience for managing these pregnant patients regarding resuscitation, and if anything new has come up which is different from the previous one, different activities as compared to previously, please, we would like to hear from you.
Ma'am, I would here like to, there is nothing new, there is nothing different, yes, but the extreme vigilance is required. So if to summarize 10 salient features for maternal resuscitation, one, whenever you activate the maternal cardiac arrest team, it consists of teams. One is adult resuscitation team, other is obstetric team. Second is the high quality chest compression, which are safe, early defibrillation, no need to wait to remove any fetal monitor, and most important, the dose of defibrillation remains the same. Third is keeping the patient supine on a flat surface and continuous manual left uterine displacement, that is irreplaceable. Fourth and important is taking the IV access, which is, of course, we generally take above the diaphragm. But then as an anesthesiologist, sometimes like when we don't get the IV access, we have general tendency to take it on the lower limb or something like that. But that won't be effective. And the important is, of course, resuscitative hysterotomy and intrauterine intervention. That is to be done only when the gestational age is approximately more than or equal to 20 weeks. and we are doing maximum efforts. The high quality chest compression has been done, and despite that there is no ROSC within 4 minutes. Then the team has to be ready, and the baby needs to be delivered in next 1 minute, that is within 5 minutes of maternal cardiac arrest. So keeping the time is very crucial. And next important thing I would like to highlight here is, as an anesthesiologist, for us, the presence of experienced anesthesiologist is important, because airway needs to be handled on time and with skill. We all know risk of aspiration, the FRC is less, oxygen demand is high, aortocable decompression is there. So your otherwise normal CPR will be a kind of less effective in this parturient. So we need to save on time at each and every step. So presence of experienced anesthesiologist is of utmost important. And I would like to highlight here, everyone has to be CPR literate, because that will, the initial resuscitation, the initial recognition is of utmost important. That's all from my side, I guess.
Dr. Bharti, you're mute. Mute hand, Dr.
Okay,
Bharti.
okay, ma'am. Okay, ma'am. I have unmuted myself. So this was all about the case scenarios, and practically we have learned that how the CPR and the resuscitation guidelines and some few things which are required to be done in pregnant females. So now we are actually open for the discussions and comments from our experts, chairpersons, and other dignitaries to basically give their valuable.
Bharti ma'am, I would like to add something to all the discussions in the end.
Yes, please.
Thank you,
Actually,
Dr.
proper.
Bharti.
Yes, ma'am. Yes, hello.
Can I take 2 minutes?
Yes, yes, please, ma'am, please.
Yeah, thank you so much. You really made it so simple and so great learning for all the delegates and for the faculty too. And I think at very onset, we should always, the labor room team should always be vigilant for the early warning signs of the collapse. And not that when it happens, we should be, and we should be prepared. It should be a multidisciplinary approach, and wherever feasible, we must initiate the code blue, and all should follow the leader. And if there is no pulse within the first few seconds, 5 seconds, then we must initiate CPR along with the hemodynamic resuscitation, along with high flow oxygen. And uterine displacement, yes, up, off, and over is the better method than giving a left lateral tilt, which we used to do in the earlier years. And CPR and defibrillation, and wherever, if 4 minutes rule must be followed, and if at 4 minutes we must start cesarean hysterectomy if the patient is not revived by CPR, and we must do regular skills and drills, not only for nurse, our residents, but also for the nursing staff. So because together only we can save the women and the baby.
Okay, ma'am. Thank you. Yes.
The things I wanted to actually add to all the discussion is, ma'am, everything, after doing everything, we need not forget proper documentation as well as debriefing the relatives and the patient whenever she is.
Yes.
Her
And
condition
we
is
should keep
stabilized.
our calm also. All throughout, we should keep calm. We should not panic. And the relatives should be informed regularly by one person, and we should depute the duties. And preferably by a senior person. The relatives should be dealt by a senior person.
So this is very important, that documentation and incident reporting is very, very important to make yourself safe and to have a proper records of all the events. Yes. So
Thank you, Dr. Bharti, for the awesome CME. And I'm very lucky to state that at our Cloud9 hospital, we have regular drills of the code blue. And even the nurses, doctors, residents, even the 4th class and security personnel, they are taught the CPR, and they know their roles, and who has to come when the code blue is announced.
Yes.
So we usually act very fast when there is a maternal collapse, and we are very lucky that we have a 24/7 anesthetist, and maternal collapse is dealt very well. Thank you.
That's very great, Dr. Monica. Yes.
Same is in our hospital also.
So I was really coming to that only. What we have talked is some some tertiary hospital which have the facilities of obstetrician or senior anesthetist and neonatologist, but we should really look for the ways where we can train our paramedical staff in the low resource setting. So that is very, very important, so that everybody is well versed at least with the basic resuscitation. And second point, I'm sorry for my bad throat. And second point is what was in my mind? I just forgot.
Yes, Dr. Vineet, you
Yeah.
are not audible. Yeah. Dr. Vineet, you are muted. I think she has some unstable connection. So,
Thank you, Dr. Bharti. Maternal collapse is a rare but a real emergency which needs to be definitely recognized, which I will, and rapid action definitely is required. Recognition is there, but rapid action, and yes, a very well coordinated webinar was there. Appreciated your efforts. Thank you. It was really insightful. Really insightful.
Dr. Bharti, am I audible?
Yes, now you are audible, ma'am.
Yeah, I think documentation in near miss. These documentations, if we are saving the baby and the mother, they should be documented in the near miss.
Yes, ma'am. And the level of delay has to be mentioned, because
Yes,
sometimes the level of delay helps to identifying the factors
Yes,
which can help
yes,
you
yeah.
basically to build up the future strategies to
Yes.
optimize the results. So
So
that
all
is
these
one
cases
important thing.
should be reported in the near miss.
Yes.
Thank you.
Shall we conclude, ma'am?
I think Ashmi, it's already 8:20.
Are we able to contact Manju, ma'am?
Dr. Manju? I'm actually stopping sharing. Dr. Manju is there? We would like to have a final words from Dr. Manju.
No, she is not here.
Okay. Okay.
So, any more questions?
So, Ashmi, I want to make a comment.
Ji, ma'am.
As a part of the NIGF academic wing, which is led by Dr. Manju Verma and Dr. Agni as a president of NIGF, and Dr. Mala and Dr. Ruby as a president, and me as a secretary. I would like to thank all the team of NIGF academic wing to help me in having this, and with all the executive of NIGF Chandigarh chapter. I want to thank all of you, and especially to Dr. Manju, Dr. Mala, Dr. Ruby ma'am for making this happen. And thank you very much to Dr.
One
Agni.
person from Jammu, Dr.
Thank you,
Rubina,
Dr.
Professor Rubina
Meenakshi,
Mirza.
for
Thank
doing
you.
a wonderful
I must
CME
congratulate Dr. Meenakshi. Excellent work
with your
done.
team, and you have
Yes.
made everyone wiser.
Yeah.
Wonderful work. Wonderful
Excellent
start
learning. Yeah.
for such a
Thank you,
difficult
ma'am.
topic made so easy.
Dr. Ragini is
Dr.
with her.
Ragini, ma'am, Dr. Ragini wants to say something.
Yeah.
Yes,
What
ma'am.
I was saying, Dr. Manju Verma is the dean of this academic wing. We should know the exact, and Dr. Mala Srivastava is the chairperson of academic wing. Dr.
Yes,
Ruby Bhatia is vice chairperson, and Professor Rubina Mirza from the Jammu Medical College, she is the vice chairperson elect, and Dr. Rohila is the secretary. So this is the hierarchy of the academic wing, and we are missing today Professor Rubina Mirza here.
Okay, ma'am.
Otherwise, it's an excellent program and very apt topic you have taken as the first academic wing program.
Thank you.
Thank you, ma'am.
Thank you. We will include her in our next presentation, definitely.
Yeah, we will keep it in mind. Yeah.
So wrapping up the webinar today, so as we come to the end of this academic session today, I would like to sincerely thank all our executives of NIGF, our speakers, chairpersons, panelists, and participants for making this CME very interactive and also very insightful. Thank you all of you for respecting time. Thank you for contributing. Thank you all the participants as well. And thank you to all, one and all, for a very smooth and a successful academic evening. So I would like to thank everyone. Bharti ma'am would like to...
Yes, I would like to thank the...
Thank you, Bharti and
Dr.
team, Chandigarh
Thank you,
chapter,
ma'am.
along with Dr. Meenakshi. Wonderful.
Thank you, ma'am. Thank you. Thank you, everyone, for making this event really fruitful. Thank you.
Thank you.
Dr. Bharti.
Thank you.
everyone.